Juan Sanchez Ramos, Fellowship Trained Movement Disorder Specialist and the Medical Director of the Parkinson Research Foundation.
Thank you, Marilyn. So here's some questions. There was a few that I'd received earlier. Let me apologize for being a little late. The traffic was held me up a bit. And I'm going to go right off into the question. One of the more interesting ones was regarding what do you know about Stem Cell of America? Can you tell us more about stem cells in Parkinson's disease? Bring us up to date. Have I ever heard of Stem Cells of America or Stem Cell of America? And it truly is Stem Cell of America because when you get treatment, it's something you have to read very fine. I went to the website. Before I tell you what's going on with stem cell research in Parkinson's disease, I'll tell you about Stem Cells of America. I printed out their website, their frequently asked questions. One of the things they never say is, what is the treatment cost? So, well, contact us and we'll discuss it. Does health insurance cover any portion of the treatment? No. The treatment is not covered by private or public health insurance. Do you take patients from outside the United States? It makes it seem like you're getting the treatment in the United States. We have offices in many cities in the United States. But if you read way at the bottom, you get the treatments in Mexico. Should be a little red flag. And by the way, I'm Hispanic. I have nothing against Hispanic, but I would be a little wary. I said, well, if it's something, they've done thousands of patients. What is the best indicator? Because, you know, they went to the website. Whoever asked me the question obviously had a suspicion there were some red flags. This is the biggest red flag. This is just a partial list of disease and conditions that Stem Cell of America has successfully treated. Notice I've never read about any of these studies. These are not studies. These are patients, they say, that have gone there, have received the treatment. And these are the conditions that they successfully treat. I'll read every one of them. I don't think a medical book has more diseases than what they treat. But anyway, it starts with A, Alzheimer's, arthritis, autism, brain damage, cancer, cerebral palsy, chronic pain, cystic fibrosis, diabetes, epilepsy, fibromyalgia, heart disease, kidney disease, liver disease, lung disease, lupus, multiple sclerosis, muscular dystrophy, Parkinson's, they don't even say Parkinson's disease, seizures, spinal cord injury, stroke, and they run out of space, so they say, and others. I mean, who in their right mind would even call them up? Who in their right mind would do it? I was kind of shocked at people. How quickly will I see results after stem cell treatment? Every person is, of course, different. That's what I tell all my patients. Each of our body's healing mechanisms work at a unique pace as they are influenced by many factors. Commonly, significant positive changes are seen between 3 to 6 months after post-treatment. At times, changes can occur as little as weeks. Well, what kind of stem cell therapy is going to produce results in weeks? I don't know. And then I was really curious, where do they get? They have a section on all the different kinds of stem cells. It's very poorly written. And I have a feeling English may not be the first language of the person who prepared it, because there's some weird language. But they don't say where their fetal cells come from. These are fetal stem cells. And where do they obtain the cells? Are they from Mexican women who agree to have therapeutic abortions? Because a fetal cell comes from a fetus, and that means it comes from, has to be aborted in order to have it. This is not embryonic stem cells, which would come from embryonic stem cells derived from in vitro fertilization clinics, that's where embryonic stem cells are derived. But a fetal cell comes from a fetus. Now, let's talk about legitimate studies with fetal cells. So, for them to treat this many patients, thousands of people have been treated in their Stem Cells of America with fetal cells. They have to do a lot of therapeutic abortions. So I don't know where they're getting their material from. Must be some black market. What's really interesting is that One of the things that brought me to Tampa from the University of Miami to the University of South Florida was that they were pioneering fetal cell grafts into the striatum of patients with Parkinson's disease. Only 3 centers were doing this. It was very exploratory. These were clinical studies that were published and reviewed, and they had to get permission from all the regulatory agencies. And it was very difficult. Columbia University, University of South Florida, and University of Colorado did a series of fetal cell grafts into Parkinson's patients. This is the real stuff, okay? Not this that I just read you about. This is for business. This is a business, and it's a scam, really. And I can't believe that anyone would fall prey to that. The people are desperate. They don't know any better. So those studies that were done at the University of South Florida involved the collection of 9 to 11-week-old midbrains from therapeutic abortions. These are people that had abortions performed for therapeutic reasons. And then those fetal brains were dissected very carefully and the midbrains removed. The midbrain is where dopamine progenitor cells have already developed. These are cells that, once the fetus develops, innervate the striatum and they become dopamine neurons. And since we grew up believing that the main problem, and we still believe this, and we still have evidence for this, that the major deficit in Parkinson's disease is insufficient survival of dopamine neurons. They gradually die away, and that produces slowness and rigidity and tremor. That doesn't produce all the other stuff that goes on in Parkinson's, but nevertheless, we're naive. What if we replace dopamine neurons that were fetal cells that are committed to become dopaminergic neurons? We already know. These aren't embryonic stem cells. These are committed to become neurons that make dopamine. And all this work was done in monkeys first and rodents before FDA would even allow it to be done. So in humans. So they would take about 9 midbrains on each side, so a total of 18 midbrains for one patient. And these cells are kind of slightly dissociated and injected surgically in multiple sites on both sides. And a total of maybe 60 patients altogether were done, maybe more, I can't recall when you pooled them. And it was really exciting because people got better. But it took about a year. By the way, I should mention, most drug studies have a placebo control because of the powerful effect of faith and belief and expectations on outcome. This is a remarkable thing. If you really believe something's going to work, you'll get some benefit. Up to a year later, you'll still have benefit. So this study, by the way, I'm going into detail to show you what real fetal cell treatment can do and what the problems were. In this study, it was a surgical sham was allowed. The only way this was allowed to proceed was that in half the patients, the surgeon would know this, but the patient didn't know, nor the physician who's evaluating the outcome. The patient had a sham surgery. He had a little bit of a bone disc removed, and the needle did not penetrate into the brain. But then they woke up from the surgery and they knew they had surgery, but they didn't know if they got the fetal cells or not. So these patients were followed for a year. The way that the experiment was considered not ethical, or what I should say ethical, because you'd say, well, it's not right to do a sham surgery on patients. Who's going to agree to do that? And the way that the problem was solved is that at the end of the year, the blind would be broken. In other words, the surgeons would, the patients and the physicians would learn whether they got the sham surgery, in other words, no implant, versus fetal cells. And if the patients who had the sham surgery desired it, they would then get the fetal cell grafted then. So they'd get the cells a year later. That's how you could give everyone an equal opportunity to receive the cells. What was really fascinating is that all of the patients in the first year got better and better as the year came to an end. All of them. Every one of them, sham surgery or fetal cell graft, shows you the power and the duration of faith, right? Of placebo effect. It's amazing what belief will do. And you just look at history and you'll see how powerful faith is. If you really believe in something, it'll transform you. But it only lasts for a while. After a while, human skepticism and evidence, the search for the true evidence comes out, and you'll be deflated. So what happened is that all of the patients got better. Every patient then got fetal cell grafts, and the study continued for 5 years until patients died of unknown causes or whatever, of natural causes. So many patients, the majority of them, continued to get better, especially after they got the fetal cell grafts. The ones that got the delayed graft got better also. And some of the patients could decrease the amount of levodopa. So it was considered a success. And then there was a big move to do fetal cell grafting around the world, and people started setting up shop to do fetal cell grafts, places that could get fetal cells easier than the United States. So a lot of studies were done in Europe. Different stem cell treatment facilities were set up in Germany and in Europe, Latin America, China, etc. In those cases, they weren't for research. It was for money, even though the rest of the story hadn't come out yet. Here's the rest of the story. Within a year in some patients, and 3 to 5 years in others, the dyskinesias started to develop, even when you stopped levodopa. So people started getting levodopa-induced dyskinesias. You all know that with chronic levodopa administration, especially when you're younger in onset, or if you take big doses of levodopa, there's not only a gradual wearing off of benefit, but one can develop excessive involuntary movements that can be just as incapacitating as the symptoms of Parkinson's disease. And usually when that happens, when I give patients levodopa, I cut way back on the levodopa, and you can stop the levodopa and there's no more dyskinesia. Of course, the patient will be rigid and akinetic. Well, when they stopped the levodopa on these people that had, quote, runaway dyskinesias, the worst dyskinesias anyone had ever seen, they continued to have the dyskinesias, even without medication. And so many of these patients had to have pallidotomies to treat the effects of the fetal cell graft. And to make the story even worse, some patients that would die of natural causes 15 years after the surgery, their brains were examined, and indeed they could see dopamine neurons had sprouted their fibers, and they stained for tyrosine hydroxylase. They were making dopamine, but not in the usual pattern that we see, because these cells were not transplanted where they should live, in the substantia nigra. They were transplanted into the striatum with the idea we're going to make a dopamine pump, a natural pump. We'll be able to use less levodopa, but the dopamine being released was released very without control, without any kind of integration into the normal loops that control movement. But what was really devastating to this whole fetal cell grafting story, and what I think is a big setback to using stem cells to be injected into brain, because remember, all of these procedures involve surgery, implantation of cells, and you have to put in a lot of cells. I told you 18 fetuses for one. And 90% of the cells don't make it. They die. And the ones that survive, when they do beautifully, but then they release too much dopamine constantly. Here's the thing. When you looked at those brains and stained for Lewy bodies and stained for alpha-synuclein, you found that these 15-year-old cells that were put in 15 years ago, let's say in this one case it was very dramatic, you saw Lewy bodies in these transplanted dopamine neurons. It means they had picked up Parkinson's disease also. Any farmer will tell you, if you're going to plant seeds in a polluted soil, what's going to happen? You won't get a good crop. So I think that's the big issue, is that the problem isn't with the dopamine neurons per se, it's something going on in the brain that results in the demise of any cell you put in there that makes dopamine. So that's the truth about fetal cell grafting, and no one is doing fetal cell grafting anymore. So people went back to the drawing board and they said, let's do embryonic stem cells. Those we can put in earlier, they're more robust. Problem with that approach is the same thing. They have to be surgically implanted. You need a huge number of them. And there was a setback for a while because of political reasons. Under the Bush administration, George W. Bush, there was a ban on the preparation of new embryonic stem cells. You were only allowed to use previously established cell lines, and they were limited. They were not the best. And when some work did go on anyway, using those approved cell lines, and if the cells were put in without any prior treatment, just embryonic stem cell, which by the way, is produced from fertilized eggs that people generate daily in vitro fertilization clinics. Infertile people can't have children. You take some eggs, some sperm, mix them together, you get fertilized eggs. The ones that are looking good, you put in back into the uterus. But there's often hundreds of these cells that are kept in the deep freeze. If the patient says they could be used for research, well, those cells could be used to prepare embryonic stem cells. And like a yogurt culture, you can grow embryonic stem cells. So you don't need that many fertilized eggs to make a large number of embryonic stem cells. Problem with the embryonic stem cells when you implant them in brain is they proliferate and become many different cell types, including beating heart cells, skin cells, etc. So in some animal models you can get tumors develop. A teratoma, they're called, which is an abnormal conglomeration of cells. Just like if you take an embryonic stem cell and put it in a cell culture dish and let it go, you'll see a strangest looking clump of cells. You'll see every cell type that you know of, all in an unorganized manner. It doesn't undergo development in a normal way, which is very regulated and sequentially controlled. Development is a miracle, how a fertilized egg becomes such an organized creature. And when you take an embryonic stem cell and just put it into a dish or put it into the brain, why do you think it's going to follow normal development? It doesn't. It follows abnormal development. So the next step is to pre-differentiate these cells in culture. You take the cells and you add a few growth factors that instruct the cells to take a neuronal lineage. So they can become any neuron type or any neural type, astrocyte, and put those in. Those work better. And so a lot of people are working with that. But again, you have the problem is you have to put many, many more cells into the brain. And you can't just put them into the striatum. You have to put them into the nigrum. It's a very small place to put in so many cells. So it's a technical problem, and the science is not up to par. Cannot deal with the mysteries of developmental biology yet. We need more knowledge, more basic research with embryonic stem cells. So there's a lot of that going on. People are going back to the drawing board about how the brain develops. And it turns out that there are ways to turn on your own stem cells in your brain, and that's where it's headed. So you won't have to have surgeons drill into your brain, put in a needle and inject in a bunch of cells that were taken from elsewhere. Could use your endogenous cells. And then people have said, and it was our work when I came to Tampa, we found that bone marrow cells, umbilical cord cells, contain a neural progenitor. We don't have to get embryonic stem cells. We can take adult tissue to make stem cells. And the problem with that is you still have to inject those things into the brain. What fetal stem cells, no, we just put it under the skin. Or we put it into the veins. That's how they do treat Parkinson's disease. You pay maybe $20,000, maybe $30,000. I know of a woman who mortgaged her house, and I saw her at the clinic. She was not a wealthy woman, and she went to somewhere in Latin America, I think it was Argentina, paid $30,000, got her bone marrow taken out. They did something, and they infused the bone marrow into her venous circulation. That was it. Go home. $30,000 less, absolutely no benefit. The only thing was she was poor and disillusioned about the medical profession. What rip-off artists they can be. I remember asking about that. I inquired of a well-known neurologist, Dr. Oscar Gershanik, in Buenos Aires at the Hospital Hospital Francés, which is a top notch. And they were doing it there, and he hadn't even heard about it. And who was doing it? It was an endocrinologist and a surgeon who were doing the procedures. And the expert in movement disorders didn't even know they were doing it in his hospital. When I say, hey, do you know that they're doing this procedure? They're advertising. I had a patient just lose $30,000 by going to your hospital. He says, well, I'm going to look into it. And I heard that these people were barred from doing that procedure. They never got any approval to do this. They just set up a little business. And it was a good hospital. So patients felt, yeah, this is a European hospital. It was founded by some French doctors. It was a high-class hospital. And they're doing this rip-off thing. Similarly, stem cell procedures being done using bone marrow in Germany, they were shut down recently because they were, I'm not going to tell you all the atrocities, but I feel that, yeah, stem cells one day will be useful for Parkinson's disease after we learn more about stem cells. We don't know enough about them. It was, first of all, it was remarkable to learn that we make our own neurons till we die. So that's where the truth will lie, is understanding what regulates the birth of new neurons in our brain, and how can we get new neurons to replace the ones that are dying. Typically, we're losing cells all the time, and most organs can replace cells. We make a whole new skin all the time, whole new lining of your gut. Many cells, many organs, every organ has got a stem cell population, a niche, where it keeps them in a primitive state until they're needed. And usually, like the liver can do that, the heart muscle can't do it very well. It becomes mostly a fibrotic tissue, so if you lose heart cells very fast, you just end up with a scar. Same with brain. But we have to learn how to harness the potential of every organ, especially the brain, to replace cells that are lost. You think if cells are lost gradually, like in Parkinson's disease, we should be able to gradually replace them. And that's going to be the solution. That would be the answer. And it's not going to be, you're not going to pay for it. I mean, we'll pay for it through taxes and so, well, we may pay for it through the drug that is developed to stimulate this, but it's not going to cost you this fee, which is, it's outrageous. Anyway, I hope no one asks me any more about stem cells. The next most common question they ask me is about marijuana. And I say, just go vote in November. One way or the other, it doesn't matter. But the fact is, someone asked a question about marijuana. Another question. I thought we were done with it, but there's always, it's interesting because not marijuana. Marijuana is an old slang word that has deleterious negative connotations. It was the Mexican slang, Mary Jane, for this plant, cannabis, which grows all over as a wild weed. It's been used in medicine since ancient times in India. If you look at the Indian Ayurvedic medicine, which is thousands of years old, they use preparations of cannabis indica for all kinds of nervous conditions and for pain, etc. So in the 19th century, Dr. O'Shaughnessy, you'd think he would have used some whiskey to treating Parkinson's disease, but O'Shaughnessy was a physician serving the British troops in India. And he became aware of preparations of cannabis for nervousness, tremor, pain, and he prepared an extract similar, following some formulas of a Indian physician, in alcohol, an extract of cannabis. He called it. It was an alcoholic extract of cannabis indica. And when he brought it back to England, he brought, I guess, a gallon back. He prepared it, and it was known as O'Shaughnessy's elixir. Yeah, and it has alcohol and cannabis. And he recommended several drops of that be dropped into your tea 3 times a day for Parkinson's disease. And in the classic book on neurology, written in 1888, cannabis indica, O'Shaughnessy elixir, was one of the drugs recommended, along with belladonna alkaloids and acid extracts of opium. Those are the only 3 drugs that were used in the 19th century for Parkinson's disease. We use 2 of those drugs even now, believe it or not. We still use belladonna alkaloids, which are have an ancient history. If you follow the intrigue of Machiavelli and the Borgias and all the infighting for control of power, the Game of Thrones that was going on in Italy at the time and all over, really. It's something that still goes on. There's a lot of conspiracy and murder of rivals. Well, belladonna alkaloids in high doses was the poison that they used to kill people. The witches in Europe for a long time used belladonna extract along with baby fat and toad skin and who knows what in a boiling cauldron. But belladonna alkaloid was the key agent for inducing altered states of consciousness. Now the belladonna alkaloids, by the way, are found in the angel trumpet. You hear at University of Florida every year some not well-informed college student heard that it's a hallucinogen, and they'll make a tea from the angel trumpet and they come to near death. They become delirious, hallucinate, and can die. But a preparation of belladonna in low concentrations was helpful for tremor, slowness, and rigidity. Do you ever wonder why it was called belladonna? I told you before, but belladonna is beautiful lady, beautiful woman, beautiful lady. And in the Renaissance, it was believed they have big black pupils was beautiful. So women would put eye drops with belladonna tincture to make their eyes big. And in fact, it's known now by psychologists that if a person is interested in something, their pupils dilate slightly. So if a young woman looks at a young man and her pupils look big, he's going to think, she's interested in me. And it's kind of an interesting non-motor communication. We don't use belladonna alkaloids for that, for Parkinson's disease. Though that's one of the side effects, dry mouth and slightly large pupils, and inhibition of the gut. But we use it in the form of two preparations that act like belladonna, but much safer, provided you don't overuse it. And that's artane and cogentin, trihexyphenidyl. Problem with that is that if you're over 60, I don't like to use it because that's a lot of people, really, over 60, that I don't like to use it unless the tremor is refractory to leave it. If the tremor doesn't get better, then I'll use a little bit of artane. And the artane can interfere with short-term memory, worsen constipation, and can inhibit the bladder. So that's one of the drawbacks to that 19th century drug that we still use. The other 19th century drug that we use, but I rarely use it, but may start using it more, is apomorphine. Remember I said acid extracts of opium was recommended in the 19th century. And an acid extract of opium contains a lot of apomorphine. Apomorphine doesn't have actions like morphine, which is a pain reliever, makes you sedated, makes you see the god of sleep, Morpheus, the god of sleep. Apomorphine is a dopamine agonist. It acts on dopamine receptors and it acts very quickly, but like all dopamine agonists, can make you vomit. It tickles the region of at the level of the blood-brain barrier that triggers vomiting has a dopamine receptor. So all dopamine drugs, including levodopa, pramipexole, Requip, and apomorphine, tickle that dopamine receptor at the blood-brain barrier and cause you to vomit. But apomorphine is available through injection, and it's very good for emergency, for a rescue. If you're suddenly off and you're in a restaurant, you can get your apomorphine, Apocrit, and inject it, or have your caregiver inject it if you can. And so again, that's a 19th century drug that has been highly, purified and approved for use in Parkinson's disease. The third one is the cannabis. Well, it brings us up to now. Can cannabis be used for Parkinson's disease? That was the question that triggered this little historical review. And yes, it can, but we don't know the best way to use it in Parkinson's disease. I think there has to be more careful research on the components of the cannabis that are best for alleviating slowness and rigidity. And it may be that it's a component that doesn't make people high. It may be that the part of the cannabis plant that makes people want to repeat the experience is called delta-9 THC. And you can have strains of plants that have very little delta-9 THC, with the high levels of cannabidiol, that may be very, very effective for Parkinson's. I don't know which one is the effective one. I do know that there is a pharmaceutical pharmaceutical company called GW Pharmaceuticals, it's British, that has a preparation that is 50% THC and 50% cannabidiol, and it's delivered through a spray in the mouth. And that would be the first one I would try. If ever it is approved as a medicine, I could write that prescription and we could do some studies with it. I'll go on to this is good, I don't have too many questions to answer anymore. See, the thing is, one question generates 100 questions. So all you have to do is ask me one question and we'll talk all day. Okay, here's another one. How does exposure to pesticides increase the risk for Parkinson's disease, especially DDT? So how does it do it? Well, the pesticides and herbicides, not just pesticides that kill insects and bugs that destroy crops or that frighten housewives, big old roaches coming up under the sink. Those are pesticides. And herbicides are used to kill plants, and herbicides are used like mad by farmers, by our government, spraying the marijuana crops that are grown in the wild. But it's true, they spray with paraquat, which is very frightening because paraquat, it'll be the prototype of how pesticides, herbicides destroy dopamine neurons. What they do is they inhibit the energy production within cells that is produced within mitochondria. They are mitochondrial poisons. And we know that the one that shed light on this was not a pesticide, it was an herbicide, was in a drug of abuse, a contaminant of a drug of abuse called MPTP, and it's very similar in structure to paraquat, which is an herbicide. And this is another bit of history that led to understanding how pesticides can increase the risk for Parkinson's disease. Well, these were people that didn't know they were shooting up into their veins a pesticide. If they knew, maybe they wouldn't have done it. These were people that were buying, this is in the San Francisco Bay Area in the early 1980s. They were IV drug abusers. They had bought a new form of, quote, heroin known as China White, supposedly from Asia. And it really was produced in San Francisco in an underground lab. Not underground truly, but in someone's laundry room. And they overcooked the formula and contaminated the Demerol, which was what they were trying to make. Meperidine is a synthetic morphine-like drug. And they contaminated it with MPTP, which is a structure very similar to an herbicide. And there's an epidemic of young IV drug abusers that develop Parkinson's disease. And as that was being investigated by getting samples of this stuff and identifying what component of that drug produced Parkinson's disease in animals, they were able to identify MPTP, and they are able to identify that it was poisoning mitochondria. And we didn't know that mitochondria were involved in Parkinson's disease until the research of MPTP suggested, well, if MPTP is causing the death of dopamine neurons by poisoning the mitochondria of dopamine neurons, maybe there's a problem like that in people with Parkinson's disease, whether or not they're exposed to anything. And sure enough, every patient with Parkinson's disease has a mitochondrial deficiency. And the mitochondria, where all the fuel is burned to make energy, and the exhaust is gotten rid of and dealt with antioxidants, well, this doesn't work well in dopaminergic neurons. In other words, there's an energy deficit, and there's excessive oxyradical production in dopamine neurons. And how did the MPTP home in on dopamine neurons? Well, this is really an amazing story, because MPTP gets across the blood-brain barrier, and in the brain, it's metabolized by something called MAO. You've heard of MAO inhibitors. Well, MAO makes MPTP into a chemical MPP that looks like dopamine. And so the dopamine neurons see MPP and take it up like it was dopamine. Hey, this belongs to me. And once it's in dopamine neurons, it poisons the mitochondria. So that's how an agent can be so selective for dopaminergic neurons and kill them, but not other neurons. Now, it turns out, because of this story, I became an expert in Parkinson's disease because I was doing my neurology residency, learning to be a neurologist, not even thinking of Parkinson's disease at all. But then there's this epidemic of people who are shooting up intravenous self-administration of this toxicant. And I realized when I looked at that toxicant, the paper came out that identified what it was, that it's similar to a whole bunch of pesticides and herbicides. So I began the next 15 years of study of environmental toxicants that destroy dopaminergic neurons. And I was able to, in one of the studies that we published that's very important, it's cited all the time, we took brains from the University of Miami Brain Bank, that people who in life had Parkinson's disease, and we took age-matched controls. We also took people who had Alzheimer's disease in life of the same age range, and we measured 18 different pesticides in different parts of the brain. And I had as a collaborator a person who probably will earn a Nobel Prize named Bruce Ames. And he was from University of California in Berkeley. But we identified dieldrin and DDT being elevated in the Alzheimer's and in the Parkinson's brain, but not in the controls. DDT was very elevated in controls as well. So it isn't DDT that's causing the Parkinson's disease or the Alzheimer's. So DDT can cause all kinds of other problems, especially with our bird population, but it certainly is one of the more benign of the pesticides. However, dieldrin, which is a pesticide banned in 1970, was used for dealing with termites. It's still used in different parts of the world for pests. And dieldrin also was found in really high levels in patients with Parkinson's disease. Since then, there have been another, rotenone is another one. There's a number of other agents. The Agent Orange, the herbicide, has also been linked with Parkinson's disease epidemiologically, and now any veteran who served in the field in Vietnam is eligible to have 100% disability if he has Parkinson's disease, because they see the link. And it, again, is a mitochondrial poison. So how do herbicides and pesticides increase the risk? Because some people have high levels of these things and don't have Parkinson's disease. So it increases the risk, it doesn't necessarily cause it. And it has to do with how those chemicals are metabolized. And how they're metabolized varies according to one's genetics. So that's why these are things that increase the risk for Parkinson's disease. There's no real cause and effect, though I can cause Parkinson's disease in an animal model if I feed them enough of the pesticide. The reason I was really surprised, because the next step of our research is to look at people exposed to really high levels of herbicides and pesticides where they happen to have a high frequency of Parkinson's disease. That was a place in Mississippi, cotton farmers near Clarksville, Mississippi. And there was a local physician who read my paper, said, you know, this small town of 15,000 people, they all work in the cotton industry. And I have a huge number of Parkinson patients. So I arranged to have their blood samples sent to us. And I said, make sure you send to us also age-matched controls that work at the same occupation. And everybody in that town had sky-high levels of dieldrin. But not everyone had Parkinson's disease. So that's when I realized the genetic factors have a lot to do with it. And it was a mixture of African American and Caucasian people, and I didn't have the the resources to start looking at the genetics at that time. This was around 1990. Now all of this could be looked at again, and people are looking at that, looking at genetic and environmental risk factors, because like everything in life, including your height, your intelligence, your personality, it's determined by a combination of genetics interacting with the environment throughout life. Okay. I have maybe room for one or... What is the difference between a simple and a complex sugar? And how much sugar should we have in our diet? As much as makes you happy. I used to tell them. I'm just joking. No. My mother, who lived to 96, was told by her internist, you know, you're pre-diabetic, you know, you have to control your sugar. And she says, what do you think? I said, well, eat what makes you happy. And she lived to 96, you know, big deal. But in general, okay, I'll answer the question. And there's all kinds of things going on. Now, a simple sugar would be just glucose. It's a very simple molecule. There are disaccharides are made up of two molecules, like lactose. It's glucose and galactose. These are two very simple unit of carbohydrates. There are three major classes of foods, of materials that we take in to utilize to keep us going and rebuild our tissue and provide energy. Those are the lipids, or the fats. They're made of long-chain fatty acids, and they can be saturated and unsaturated, and that's what's always under controversy. Should we eat polyunsaturated and saturated foods? But I'm not going to get into that. And then there's the proteins. They're made up of, all of these are polymers, by the way. You know what a polymer is? Made up of units. I tell Catholics it this way, or even Muslims. You know those beads, rosary beads? Well, that's a polymer, the rosary bead, or the chain beads, or your necklace. The monomer is the single bead. So proteins are made up of polymers of amino acids. The single bead in a protein is called an amino acid. Levodopa is one of 20 beads, one of 20 amino acids that make up all proteins in your body. And in foods that you take, the complex carbohydrates are really intriguing. So cellulose, it's a very complex carbohydrate. It becomes rigid. It's part of plants. The cell membrane of a plant is made up of a complex carbohydrate. Starches, potatoes, those are complex carbohydrates. When we digest those, we digest all of these things, we break them down. We have enzymes in our gut that break them down into beads. So we can recycle the beads, we can recycle the fatty acids, and we can recycle the glucose. What the glucose, the complex carbohydrates take a lot of energy to break down. And they make circulating glucose, which then is the unit that is broken down to provide energy. If there's no glucose available, the next best source is a fatty acid found in fats. And that's taken up. So if you're not eating anything, you use up glucose is usually stored as a polymer in your liver, right? It's amylose is what it's called when sugar is made into a polymer in your liver, and it's stored for energy when you need it, but it's short-term storage, whereas fats are stored as you know where. No, fats are a very important part of membranes. Every membrane is made up. What determines inside, the barrier between the inside and outside of a cell is called the cell membrane, and they're made of lipoproteins, fatty protein. So a lot of the structures in our body are made up of these combinations of fats, lipids, and proteins. So a complex carbohydrate is just a very complex three-dimensional structure made up of units of sugars, of small monomers of sugar. So what happens if you're exposed, like we are, to a lot of simple sugars, like in soda, or pop, or Coke, like many of us have, or that we sweeten everything? What happens is that with time, the ability to utilize and take glucose into the cells becomes compromised because of insulin resistance. Insulin is a hormone that allows glucose to be taken into the cells. If you don't have insulin, glucose just circulates in the blood, and you end up with all kinds of hyperosmolar, comatose state. Or if you have too little glucose, because you got too much insulin, and all was sucked up, and there's not enough, so then you end up with a hypoglycemic coma. So glucose is very highly regulated by insulin and by how much you take in. As we get older, the ability to utilize glucose because of excessive bombarding of our system with free glucose, it gets compromised and one becomes diabetic, type 2 diabetes. Type 1 is something genetically determined, not making enough insulin. So yes, it depends on what you want from your life. The small pleasures of life, or do you like the idea of a long-term quality of life? So what I would recommend, don't add sugar to anything. If something is very sweet, watch it. Try to eat complex carbohydrates if you need a carbohydrate. There's a move towards using less carbohydrates and more fats and more protein. But I think it's a mixture of all three that are needed. And people always ask me, what about carbohydrates, proteins, and Parkinson's disease? Well, in general, glucose enhances the transport of levodopa across the blood-brain barrier. So if you have an espresso with a heap full with sugar, like espresso should be, because it's too bitter, people put really sweeten their coffee, and have your levodopa on an empty stomach, you'll be amazed how quickly you come on, because the levodopa is much more rapidly taken from blood to brain. If you have that levodopa with a yogurt or a milkshake, that levodopa may take forever to get across the blood-brain barrier. And it's basically because there are circulating amino acids, the building blocks of proteins, that compete with levodopa for entry into the brain. So there's a lot of little things like that that I will bring up to my patients when they notice that, it seems like after dinner when I take my cinnamon, it doesn't seem to work. Whereas in the morning it works okay, and then, so in the early stages of the illness, you don't have to worry about that, about your diet. But later on, you need every molecule of levodopa to get into your brain, and then you can start watching how much protein you take when you take your levodopa. Let's see, I think that's it. No more questions for the moment. Thank you.